And thank you guys for inviting me to come and talk about exercise as medicine in childhood myositis. But I'm actually going to expand the topic to really talk about other aspects of lifestyle as medicine for kids with myopathy. Now, when I was a kid, my father, who was an academic pediatrician himself, told me that if I got plenty of fresh air, ate the right food, got a good amount of sleep, and got good exercise, that would be optimal for my health. Now, he was a pediatrician. He believed in vaccinations and medications and sanitation, but he said these are the keys to optimal health. And a good and fun part of my research career has been trying to see, does this apply to children with chronic illnesses like myositis as well, and can it help improving optimal health? This is like a map of what I'm going to be talking about today. I'm going to start by talking about well, that looks fine. Okay, I'm going to start by talking about muscle disease and the fitness problems that are associated with it. Talk about some of the tools that we use, because in order to do research, we have to have the proper tools to assess fitness. And I'm going to suggest to you that we might want to consider in our clinics something called a Wingate test. Talk about the role of exercise as medicine in dermatomyositis, and then focus a little bit about sleep and sleep disturbance, and finally talk about nutrition and its role in dealing with chronic disease, and especially myositis, and supplements that we might be using. Now, this is the rationale, and I think a reasonable rationale, for considering why exercise might be medicine for children with myositis. So if you have muscle disease and muscle inflammation, that leads to dysfunction, weakness, and inability to use your muscles as well, which eventually leads to activity limitation. This is what we see with our patients all the time. And it's at least possible, and perhaps likely, that activity limitation negatively impacts on muscle inflammation and muscle disease, but it certainly leads to deconditioning. And deconditioning further restricts participation in the kinds of things that children should be doing and like to do, and that becomes a vicious circle, where the more you restrict your participation, the more deconditioning you have. And there is good evidence that children are, in fact, deconditioned. So studies from Holland, from America, and from Brazil have all shown that if you look at children with dermatomyositis or other forms of myositis, that they perform very poorly on fitness tests compared to matched controls. And that's not just when this disorder is active and acute. So these fitness deficiencies persist well into the course of illness, and we know from studies from Denmark and Norway and Holland that these fitness deficiencies persist even through remission into adulthood. Now, can lifestyle help? Can exercise help? There's at least a physiological basis to suggest that proper amounts of exercise can improve inflammation and reduce rheumatic disease. So we know for adults, for example, that if you exercise too much, then you markedly increase your susceptibility to infections. But if you exercise at a moderate and appropriate amount, then you increase your abilities of your body to fight infection. You reduce infections by about 30%. In children, although there's much less known about it, there are potent anti-inflammatory effects of fitness exercise. So reductions in IgA, good effects on neutrophils, appropriate effects on NK cells, and so on. But before we can study it, we need to have the proper tools for assessing fitness. And I want to talk just a little bit at this point about that. Almost 15 years ago, Tim Tonkin and the group in Utrecht showed us that standardized exercise tests are possible and they're safe, and they can certainly reliably measure fitness in children with myositis. So standardized exercise tests like, do you guys all, just show of hands here, do you all know what I mean by standardized exercise tests, like looking at VO2 max or VO2 peak and things like that? Everybody knows? Yeah? Okay. Those things work fine. We've been mostly interested, though, in looking at habitual activity, which is probably, in my mind anyways, more appropriate for children and children with chronic disease. And the way that's most often done reliably in adults is using things called accelerometers. Has anybody here got an accelerometer? Show of hands. Yeah, you probably all do, right? Like your cell phone has an accelerometer on it. Your smartwatch has an accelerometer. My smart ring has an accelerometer on it and measures all my activity levels. And that's supposed to be able to tell us how much energy we expend during the day and can allow us to set goals to improve fitness. But we wanted to know, these have been done primarily for adults, with some work looking at healthy children. How do they apply to children with chronic illness like myositis? And so what we did with our colleagues in Utrecht is we looked at 210 children. That's 30 in each of 6 disease groups and then controls. 210 disease kids and then controls, 30 in each group. And what these patients had was they had juvenile arthritis, dermatomyositis, cystic fibrosis, cerebral palsy, muscular dystrophies, congenital cardiac disease, and hemophilic arthropathy. And we wanted to see, because the hypothesis is that, let's say you have myositis. If you have myositis, you likely have a different amount of energy expenditure for the same types of movements than a healthy child would have, because your muscles aren't working the same way. If you have arthritis, you have a different gait pattern, and you may expend energy at a different level for the same number of accelerometer counts. We wanted to see if that was true or not. So what we did is we got a portable metabolic cart that the kids could wear and breathe through the breathing apparatus so we could measure their actual energy expenditure. And then we strapped a whole bunch of commercial accelerometers on their hips in the proper fashion, and we ran them through a series of activities that we thought are the kinds of things that kids would normally do, like playing computer games, doing chores. Yeah, I was going to say maybe not all of your kids do chores. Certainly my kids didn't do too many chores, but walking around, climbing stairs, doing some more vigorous activity like running on a treadmill. And we measured what did the gold standard, that is their actual measured energy expenditure, how did that compare to what the accelerometers told us? And what we found was that for these children, the accelerometers did a terrible job. This table is showing you the different diagnoses on the column to your left, and the intra-class correlation coefficient. Now, the intra-class correlation coefficient is a statistic that tells us the agreement beyond chance. Beyond chance meaning if I just flip 2 coins, by chance alone, they might both show heads. It goes between 0, which is absolutely no agreement at all, to 1, which is perfect agreement beyond chance. And I've just outlined the JDM patients for you. You see that the intra-class correlation coefficient, the agreement, was as little as 13% above what you'd expect from chance. And that was the worst of all the chronic diseases that we looked at. Now, we were able to make this better. So this is just, I'm just showing you here the ActiHeart accelerometer. The black dots show you the actual indirect calorimetry, that is the gold standard on the horizontal axis, and the accelerometer determined energy expenditure on the vertical axis. And you can see that the accelerometer was consistently overcalling the amount of energy that was actually expended. But we could tweak the math behind it, and those are the white dots, and get an almost perfect agreement. And we could do this with all the other accelerometers. So we have different sets of equations, different math that we can use for accelerometer counts, for example, for Duchenne muscular dystrophy or for dermatomyositis, that gives us better understanding of what accelerometer counts show us. That being said, I don't think that's the real benefit of what we might do with accelerometers. This is a pilot study. This is not children with myositis. This is children with arthritis. And Leanne Heel, who's a fellow with us, said she wanted to do this project, so we said, fine. Could we encourage kids to be more active by giving them wrist-worn accelerometers that they would take home? This was a pilot study not meant to show statistical significance, but rather show feasibility. And what we did is we took a group of kids with arthritis. We had no budget for this study, so I bought super cheap versions of something like a really cheap version of a Fitbit, which was a problem because they broke more often than they worked. But what we found is the kids liked it. They said they increased their activity. You can see, I've shown you separately here for boys and girls. There were because arthritis, there were quite a few more girls. And you can see they actually did improve their energy expenditure and their activity, although it wasn't statistically significant over time. And they all agreed that this was a worthwhile thing and a worthwhile thing to study. Now, we haven't done this yet with children with myositis. Yet to come, a grant has gone in where we're going to be looking across a wide range of children with chronic diseases, including children with myositis, to see if, in fact, we can motivate kids to be more physically active by using, well, we'll use real Fitbits for the funded study. Along with an international group of collaborators, for doing the kind of research that's necessary to be done, we've come up with a core set of exercise test measurements. And we've seen in rheumatology different types of core sets, and the pink is for children there. So you can see that we should do a cycle test for peak VO2, a 6-minute walk test, measure muscle strength using the manual muscle test and a hand grip strength, and do a test of muscle function, which for children should be the CMAS, right? The Childhood Myositis Assessment Scale, which is a big battery of tests and takes a long time. In our clinic, every patient gets seen by our team and our physiotherapist, and they get a CMAS and a manual muscle test, and we do a variety of other tests of fitness and muscle strength and muscle function, and the whole thing takes about 35 minutes or so. But we were really interested in something that didn't come up in the core set list, but has been studied in kids with dermatomyositis before, and that's called the Wingate test. Now, a Wingate test takes 30 seconds. And what you do is you sit on a bicycle that's got resistance adjusted, and you cycle all out as fast as you can. Has anybody ever tried to do anything like that? Turns out, if you're an adult, you want to puke when you're done this, even though it's only 30 seconds. But it does give us an estimation of peak power and fatigue index, and the whole thing's done in 30 seconds. Kids don't generally run marathons. And so VO2 peak and things like that aren't as relevant for the kinds of activities, especially that younger children do, than they would be for what happens when you're in your 30s or 40s. Kids generally have activity that's high bursts of energy and then followed by periods of rest, right? And so we've been really interested is, could we replace all of that 35-minute assessment with a 30-second assessment using the Wingate test? And this is unpublished data. The paper's just being written up right now. But what we did is we took 26 children in our clinic, gave them the 35-minute test and a bunch of other things. And we sat them on the cycle for 30 seconds and had them pedal, put the pedal to the metal. Really, they just pedaled all out. And it turns out if you're a kid, even if you have dermatomyositis, and even if the dermatomyositis is quite active, you don't puke when you do this. You're just built differently. These kids, this is the satisfaction survey we did at the end. You see the questions there are, it's the percent is the bars. Was it easy? Was it fun? Would you do it again? And should it be a regular part of the clinic? And the kids said, yes, it was easy, it was fun, I would do it again, and it should be part of our regular clinic assessment. On the scatter plot, I'm showing you on the vertical axis their peak power, which we got from that 30-second test. In fact, we got it from the first 10 seconds of the 30-second test. On the horizontal axis is the CMAS score. You can see that the correlation is very high. In fact, the correlation was high with all the measures we do, with manual muscle testing, with time squats, with all the different things that we do. But the difference is that with the Wingate test, the peak power, the scores are distributed across a wide range. But look what happens with the CMAS. I circled it in red there. That's a huge ceiling effect. So as you get stronger, you hit 52, and you can't go above that because that's just the way the CMAS is done. So in fact, in many ways, this peak power test would give us more useful information about how our patients are progressing and doing over time than a CMAS would. This, again, was just a pilot study. It was a summer student project, but it's something I think we're going to see more and more in our clinic. I mean, I bought a bike to do this, so we got to use it. But the kids liked it, and it really it might even save us a physiotherapist salary, right, to do this. I have lots of physiotherapists. That's different. I'm in Canada. That's a whole different thing. What about then actually using exercise? Now, we've done in Toronto a number of studies about actual exercise interventions in other conditions, not in myositis. The best work that's come, in my mind, about introducing exercise in myositis comes from Esther Habers, who was a PhD student in Utrecht, working with Tim Talkin and Annette and the rest of the group. And the study that's most relevant for what we're talking about was the Muscles in Motion study. Now, this was a study where they had 26 patients. They were randomized to 12 weeks of interval aerobic training, as well as some strength training, sit-ups and push-ups and things like that, or to a weightless control. So half went in the training group and the other half went in the other group. What they didn't show in this study was an improvement in peak VO2. That's not surprising. You almost can never train kids to improve their peak VO2. We've learned that in the studies that we've done. But what they did show was an improvement in the trained group in the Child Health Assessment Questionnaire, so the function got better, and they got stronger. They could jump better, they could do better push-ups, and better sit-ups. And it was safe. Nobody got worse by going through 12 weeks of intensive training, and it was feasible. They were able to do it. So there are improvements in physical function in kids who get exercise training over and above what they would normally do with dermatomyositis. And our Danish colleagues have looked at this in patients in remission. So this was 12 patients, I think it was 12 patients, sorry, 10 patients, a 12-week program, 10 patients, a 12-week program. This is not a controlled study. This is a before-after study. And what they looked is that, remember, you're still not fit if you have dermatomyositis, even as an adult. Many patients retain problems well into the future, but you can train them. This is looking at VO2 max on the horizontal axis. The black bar is before training, the gray bar is after training. And with training, you can substantially improve your fitness, even when you're in remission with chronic muscle changes. I did say I wanted to look at some other stuff too. I'm particularly fascinated by sleep and its role in health. And we're just about to start a randomized trial in Toronto. Like, we're about to enroll our first patient next week of a sleep intervention where essentially we're bribing kids to sleep more and to look at its relationship to health and childhood chronic disease. I can't show you any results because we're just starting. But I think this is particularly important for children with dermatomyositis. So we had done a study. This study was JIA and dermatomyositis. There were 40 dermatomyositis patients here randomly sampled from our clinic using a random sample algorithm, so it should be representative. And we used validated sleep questionnaires. And what we found is with our myositis patients, 40% of them had a significant sleep disturbance. And I imagine probably all of them had some sleep problems. But the sleep disturbance was highly correlated with pain, fatigue, not surprisingly, and health-related quality of life. So if you don't sleep well, you have a worse quality of life, you have more fatigue, and you have more pain. And so I think sleep is something that we should focus on, and we need to prove that it actually works. But in almost any other childhood chronic disease, asthma, diabetes, obesity, you name it, where we've shown that we can intervene by improving or lengthening sleep, we've shown improvements in health. And I think the same thing is going to hold true with dermatomyositis. We just need to prove it. Anybody here have children of their own? Any of them get enough sleep? Occasionally? Yeah, that's a whole other issue and one that we need to address too. But, you know, there's lots of studies to show that especially adolescents have marked sleep restriction, and all the devices and all the things that we have now aren't helping. This is something I think is really important. Now, you know, one of the things that my dad told me is you got to eat the right food. If you eat the right food, you're going to be healthier. I think studying diet in chronic disease is horribly complicated. I think we're learning much more now about the interaction between our microbiome, our response to foods, and a handful of genes that seem to regulate things like glycemic response and things like that. So to study a dietary intervention, and the reason probably why, you know, my patients are so interested in this, why none of them have been able to find a consistent diet that works across all these patients, is that it's probably very personalized. If you have a different microbiome, you need a different diet. If you have different genes, you need a different diet. But one thing that we can study that's a little bit simpler is giving supplementation. And the reason for that is we know, and some of these studies go back a long way, we know that the muscle use of energy, the muscle energetics is abnormal in patients with myositis, both adults and children. And we know that from things like MR spectroscopy. So we don't utilize energy. We had some talks yesterday and today about how the mitochondria are damaged and affected in these conditions. It's not just a problem with calcinosis, it's a problem with muscle energetics as well. The currency, right, all of us remember from medical school, the currency for muscle energy is adenosine triphosphate. And when ATP splits off that phosphate group to make ADP, that provides the energy for muscle contraction. And we need to recycle ADP back to ATP by providing new phosphate groups, and that comes from creatine phosphate. And so athletes, for decades and decades, have been driving that process forward by providing more creatine to sop up more phosphate and moving this cycle along. And so it seemed very reasonable to use creatine in muscle disorders. And in fact, this is the Cochrane review looking at muscular dystrophies. You can see the plot over there, and what's being looked at right here is a global assessment of improvement in muscle function, but there's other things too, that 4 randomized trials, look at the diamond, show that creatine supplementation leads to improved global muscle function in patients with muscular dystrophies. We also know that in adults who are given an exercise program and creatine supplementation, that they improve their muscle energetics and their muscle function from one small randomized trial. However, the study from Sao Paulo, which was a crossover randomized trial, did not show that creatine supplementation led to favorable outcomes. So given that disparity in the research findings, we wanted to study it in our patients with dermatomyositis. And to do that, first we did a pilot study. And in that pilot study, we took 13 kids with dermatomyositis, most of whom were quite stable at this point. They all had probable or definite. They were between the ages of 7 and 18, and they were all on a stable course of medications and had really stable disease too. In fact, most of them were doing very, very well. And we used something called a multiple baseline, a randomized multiple baseline design. What that meant is that all the kids eventually went on creatine, but they went on it at a randomly different time. So we could tell whether the improvement, if they had an improvement, was due to creatine or they just got better over time. So we could separate that out using this randomized multiple baseline design. And we studied them with things like that Wingate test every month. And we also did exercise MR spectroscopy at the beginning and the end of the study. We did a number of other things too. We looked at their ability to jump. their hand grip strength, the IMAX core set. We looked at health-related quality of life, adherence and satisfaction with the treatment, and their physical activity. The way we looked at muscle energetics using that MR spectroscopy, and some of you may have this at your centers, is we have a non-magnetic, it's not really a bicycle, it's more like a stepper, like a step trainer, that fits in the MRI, that we can exercise the kids using a gated MRI protocol in the MRI and look at, well, spectroscopy. I mean, we look at phosphate utilization, energy utilization, but I guess you could look at tons of different things while the kids are exercising and just immediately after exercise. Now, importantly, the creatine was very well tolerated. We didn't really see side effects. There was very high adherence. But in this pilot study, the small study, we didn't see any change in clinical parameters. So the patients weren't stronger. The Wingate test, which I'm showing you here, didn't really change. And it wasn't really expected to. This was a pilot study. But gratifyingly and surprisingly, muscle energetics using that exercise MRI did improve. So there was increased ATP production using the aerobic pathway during exercise recovery. There was decrease in the ratio between inorganic phosphate and phosphocreatine post-exercise. There was decrease in the anaerobic glycolytic metabolic stress. And there was an increase in total ATP production in those patients after creatine supplementation. And on the basis of this pilot study, we applied for and were granted a CureJM grant to look at exercise combined with creatine and coenzyme Q10, which we think is actually going to be a more powerful cocktail and has been used in a number of other neuromuscular diseases. And we're about to get Health Canada approval for that study, which was a long and arduous process. So maybe next year, or in a year and a half, we'll be able to give you the results of that. And hopefully we will see a clinical benefit with that kind of supplementation. So we've come full circle. I obviously am a believer, but science has to rule, that my dad was right. And that we should be focusing not just on the research, but on the implementation of improving sleep habits, figuring out how we can tackle supplementation and dietary effects, making sure kids get plenty of fresh air, and a good focus on exercise, which we now know is beneficial for kids with dermatomyositis. Thank you very much.
Thank you, Brian, for this wonderful talk and addressing such a, in my opinion, important aspect of our treatment. I have actually two questions. The sleep disturbances, did you look into the corticosteroid treatment at that time, or?
Yeah, it's quite interesting because one would have predicted beforehand that corticosteroid treatment would have had a big influence on those patients who did or didn't have a sleep disturbance. And we had a lot of JIA patients, 114, who weren't on corticosteroid treatments. And it turns out, perhaps because we only had 40 JDM patients and many were not on corticosteroids at the time of the study, we weren't able to show that it was worse on corticosteroids. But I think anybody's experience would be that, especially early on when high-dose corticosteroids, it's whatever was bad there is even worse. And so one of the things we do in our clinic is try and rapidly taper steroids and not put kids back on corticosteroids, even if there's a flare in the future, if there's some way around it. And that's one of the reasons.
Yeah, thanks. The second question is on the creatine study. I can imagine that it is more beneficial for long-term damage in the muscle. Are you looking at outcome parameters for like mitochondrial damage in these kids while they are on creatine and training schedules?
And Annette, do you mean outcome measures other than the MR spectroscopy?
Yeah, biochemical outcome measures
So we're not planning to do that in the CureJM funded study. We're not funded to do, there's a limited amount of money that we could do that. Our patients do all participate in biobank studies, as you know.
I know.
And so the samples will be sitting there if someone enterprising wants to study them.
Because I can imagine that the long-term outcome is improving rather than the shorter time to like clinical improvement in physical fitness. Damage in muscle, damage in capillaries, and so on.
I think what we typically see is that acutely when patients are very inflammatory, that anti-inflammatory therapy leads to such huge improvement that we probably would be masked by any kind of supplementation. I think this is really important in those patients who have now either in remission or in very stable disease, who still have functional deficits, of whom we have many patients. No, not everybody. Including in this study, the creatine supplementation study, I had one of my patients who, although he had bad disease initially, was captain of the high school water polo team and a judo expert. So some kids perform very, very well, but many still have a residual functional defect. And I think those are the ones where we should really be thinking about these kind of therapies. Laura.
Lovely talk. And what I wanted to ask you is this whole business about sleep disturbance. It's a complicated problem. And I thought maybe what you might want to do is to incorporate something like one of Kavi's instruments of promise for anxiety. Because what I have heard over so many years is the patients have trouble getting to sleep. And in fact, we often put stars on the ceiling or something so they could think outside themselves and relax. And we talked about taking a warm bath before you go to bed and all these other things. So there is a fascinating book, which I'm going to send you, which is about sleep and about learning and everything else. And everything that your dad said was right about it. So.
But Lauren, that's a great suggestion, and we are using promise measures in our clinic now. We've just done a study, and I'll talk to Cave about the particular anxiety measures, which should be possible to incorporate in the study. So we haven't enrolled anybody yet. Okay.
Patients and families are always asking us about like dietary interventions, so I'm sure that's the same in your clinic. Do you actively suggest supplementation to your patients when they ask about it?
So I'll tell you what I tell my patients when we talk about diet, and then I'm going to go on from there. So I don't usually talk about supplementation because we're in the middle of doing these studies, and I haven't yet proved that it's going to make people better. The usual question, though, relates to elimination diets. Like if I cut this out or I cut that out, am I going to be better? Am I going to reduce the inflammation? And I do think, from what I understand, this is such a complicated thing that you just have to try it and see. Because what may work for Johnny doesn't work for Betty. And so I'm highly encouraging to families in my clinic to adopt and try different strategies and see what works for their child. We are going to we're just doing a big systematic review right now on the relationship between microbiome, inflammation, and diet. There's something like 4,000 studies that my team is going through, trying to put this all together in anticipation of a grant that I'm not totally sure exactly how we're going to do it, but where we're going to try and target particular microbiomes with different dietary strategies, because one of the best ways to fix your microbiome is to change your diet, right? Like those germs eat certain stuff, and you change it, they're going to probably better than the antibiotics or fecal transplants or things like that. So we're going to target microbiome to see if we can see a change in inflammatory disease activity. But that's a long process, and we're just not even quite halfway through the systematic review that's going to inform that. So I don't have a smart answer for my families other than just try it, try different things, and see what works. Well, thank you, everybody.